Hello to all my dear students. Today let us start with conjunctiva. So when we hear this heading, conjunctiva, what crosses in our mind? Oh, it's a very simple chapter. Yes, but what is very important to understand is a lot of questions are asked in your PG entrance. So let's start and try to learn all the Q's and double Q's in conjunctiva. Yes, it is a factual chapter. We'll try to enjoy it as much as possible, right? Okay, so conjunctiva, first of all, we come to the structure. We all know that conjunctiva is a thin mucous membrane on your ocular surface. What are the three parts of the conjunctiva? The three parts will be your bulbar conjunctiva, right? So the front part is covered all by bulbar, then it reflects to the lids, right? And when it is reflecting, that fold of conjunctiva is what is called fornix, and then it is covering your palpebral conjunctiva. So if you look at this diagram here, this slide, have a look at it. So what are the three parts? This red part, this one is your bulbar, right? And this fold is, this one is your fornix. And under the lids becomes your palpebral conjunctiva. This is simple, nothing very big to understand, right? So in front is your bulbar, it will reflect, that is the fornix and palpebral. Please note it down, thin mucous membrane on the ocular surface divided as palpebral, bulbar and fornix. We have drawn this diagram in our introduction chapter also, where I have made it very simple how to draw it. So this becomes your bulbar, right? And the fold is called fornix, and under the lids, this is your palpebral conjunctiva. Remember this? Okay. Next important thing that we will learn is that when you see fornix, how many fornices are there? Please don't answer two. There are 4 fornices. Okay. Even fold of conjunctiva is on the medial and lateral side. So we will learn how many fornices? 4 fornices. And very important, superior one is the deepest. The superior fornix is the deepest. Okay, and what happens, just in connection to that, I'm giving you an important information here that sometimes in old age, this superior fornix can become really voluminous because of disinsertion of the levator palpebral superioris. So it will be like almost like a groove where the foreign body can get entrapped. So that is what is called giant fornix syndrome. I'll show you the slide, but as of now, just write down what is giant fornix syndrome. It is nothing but generally seen in old age with a, you can say, voluminous superior fornix. So palpebral conjunctiva, we can divide into 4. So when you say the marginal, it is covering the 2 millimeter on the margin. That is your marginal palpebral conjunctiva. Okay? Then on the tarsal plate, that becomes your tarsal. And then comes the orbital part of the palpebral conjunctiva that you have to keep in mind. And you know, just between the tarsal and the marginal, if you look at the lids, right? So there is, if this was your marginal, right? The margin of the lid, and this is the marginal. And here starts the tarsal. Okay, if you see the lid. So there is a groove here. And this groove is what is called sulcus subtarsalis. Just keep remembering this term. So if you think your own eyelid, it will be easy to understand that just from the eyelid margin and between that and the tarsal plate is a small groove. You know? So that groove is what is called sulcus subtarsalis. And what is the clinical application here? That foreign bodies tend to lodge in sulcus subtarsalis. Keep this in mind. Okay, so these are the 4 parts we have to keep in mind regarding the palpebral conjunctiva. Okay, when you are talking about bulbar conjunctiva, so the bulbar conjunctiva is of course stopping at the limbus, and it is starting from the, so a whole of the anterior sclera till the limbus is your bulbar, correct? So it covers the anterior sclera till the limbus, but doesn't cover the cornea. We all know that, very simple. Now what happens is, when it is covering the anterior sclera till the limbus, at the limbus, this conjunctiva, so give the heading bulbar conjunctiva. So this is all anatomy we are discussing, especially what are the points very important and of clinical importance. So bulbar conjunctiva is covering the anterior sclera. At the limbus, it joins with the Tennant's capsule and it joins with the episclera. So at the limbus, please note down, when it is joining with the Tennant's capsule and episclera, what we get are, this is the limbus, okay. So what happens? There are ridges due to the fusion, okay. So these ridges that are formed due to the fusion of conjunctiva with sclera, with the episclera and Tennant's capsule, these are called reti ridges. And the space between the two, this is what is palisades of Vogt. Now this one is important for your exams. Palisades of Vogt, right? Okay, so this palisades of Vogt contains the limbal stem cells. Can we remember this? This is where the limbal stem cells are located. This is very important. It is the stem cells which is giving rise to continuous renewal of the corneal epithelium is through these limbal stem cells. Isn't it? Okay. Exam question. Time to discuss an exam question here. That what is the marker for the limbal stem cell? So this has been asked, stem cell marker. This is your cue. So write down limbal stem cell marker will be, many of you can answer this, it is ABCG2. ABCG2. Okay, then we talk about next important. So very quickly we learn that it's a thin mucous membrane dividing into bulbar, palpebral and fornix. And fornices are 4. It is also called cul-de-sac. Fornix is also called cul-de-sac. And how palpebral will be from the mucocutaneous junction at the lid till covering the whole tarsal plate is palpebral, and how we divide this palpebral as orbital, tarsal, sulcus subtarsalis and margin. Okay? Acha, sometimes the foreign bodies, when it is lodged there, it needs a double eversion of your lid. So keep in mind double eversion, especially you will learn in ocular injuries, whenever there is any acid or alkali injury also, when we are washing, we always double evert and then wash the lids and all. Right? So double eversion is either you can, if you're very pro, you may do it with your finger, but it is difficult. Then what is the instrument? We call it Desmarais retractor. Okay, just know this. You can write it in sulcus subtarsalis, that it is sometimes requiring double eversion of the lid, and this double eversion of lid is mainly we can do it by Desmarais retractor. Okay? Okay. Now we next talk about, once we know the different parts of the conjunctiva, we know about the structures at the limbus. Now we will talk about histology, right? So what are the different layers in the conjunctiva? Very simple. So there are 5-layered epithelium. First of all, you should know this. Okay. So it's a 5-layered epithelium, and then there is a stroma. Now stroma further is divided as loose connective tissue is what is called adenoid layer, and this adenoid layer is what is? Adenoid layer is substantia propria. Substantia propria. Okay. And what is the lower one? We will learn. This is your fibrous layer. The next one is your fibrous layer. It is more denser. So this whole thing is stroma, and this is your epithelial layer. Simple? Yeah. So when you talk about epithelium, it is, of course, we will learn non-keratinized. I'll show you all the slides. First note down with me. Non-keratinized layer of generally stratified squamous epithelium. This can be your exam question. They ask for cornea and conjunctiva both. So we can make a cue that we have to keep remembering this. Right? The basal cells may be cuboidal. The basal cells can be cuboidal. But rest are squamous, stratified squamous epithelium. Okay? Okay. So once we know this, okay, so basals are of course are cuboidal, and what about the rest of these 5 layers that I'm talking about? Okay, I didn't mention the shape. The shape will be generally polyhedral. I don't think they will ask you this. What they will ask you? Non-keratinized, stratified squamous. Let's remember this much. Then, of course, the stroma. And okay, before that, epithelium, what are the things in the epithelial layer? Very, very important. Don't forget, goblet cells are present in the epithelial layer. Okay? So, goblet cells, they are present in the epithelial layer. This is your exam question. Where are the goblet cells maximum? So, maximum, of course, is inferiorly in the inferior fornix, but where it is mainly inferonasally. Okay, this is your exam question. So, maximum inferonasally. And suppose they now want to ask you about where it is minimum, we are going to answer minimum goblet cells are present superiorly. Minimum goblet cells are present superiorly. Okay? Okay, what else epithelium cells contain? Some lymphocytes and mainly melanocytes and some lymphoid cells, right? So, epithelium has goblet cells, epithelium can have lymphocytes, and epithelium can have melanocytes. Especially please remember the reti ridges that you learned has melanocytes. That's why it's a little pigmented around the limbus. And we are going to learn in your uveitis chapter that how in case of VKH syndrome, there is what do you call it? It has depigmentation around the limbus, and that is called Sugiura sign. I'm going to mention that in that chapter as well. Okay, so once we know this about epithelium, we talk about stroma, of course. Now I said stroma is a loose connective tissue, is what is called substantia propria. Now this substantia propria will have all the blood vessels, the lymphatics. If you want to write it, write it. So these have blood vessels, right? So stroma will have the blood vessels, the lymphatics, and of course the lymphoid tissues. Now lymphoid tissue mainly lymphocytes and plasma cells. Okay, so I want you all to be familiar with one term here. Interesting term. What is CALT? C-A-L-T. So note down, this is nothing but conjunctiva associated lymphoid tissue. Okay, so just on whatever you have learned in epithelium, it is the lymphocytes here, in the stroma, lymphocytes. So this is all what we mean. This is all broadly termed as conjunctiva associated lymphoid tissue. This is very, very important for the immune system of your ocular surface. Okay? Just know this term. Okay. When we talk about this, we will next talk about, okay, what about the denser part? Denser part was the containing mainly collagen and elastic fibers. That is the dense part of the stroma has mainly collagen and elastic tissue. Right? Of course, the vessels and nerves can be present, and rather the nerves are more deeply situated in the conjunctiva. Keep this in mind as well. Isliye, this is the reason we don't very frequently feel pain in mild conjunctivitis. Right? It is only when there is a corneal involvement or the severe conjunctivitis, the threshold decreases and we start feeling pain. So pain generally is not a feature of a usual mild conjunctivitis. So if you're asked ever why, because all the nerves are deeply seated in the fibrous layer. Right? Okay. Let's see the slide. So we were talking about the different parts of conjunctiva, which we have discussed in this slide. Coming to the next one. Okay. This also needs a mention. What is this arrow showing? This is again a fold of conjunctiva, which is almost synonymous with the homologous with the nictitating membrane in the lower animals, right? So this fold of, what is important, that there will be a collection of the tear out here, and that collection, so this is, everybody knows plica seminolaris? Just know the name. And the collection of the tears out here is what is called lacus lacrimalis. Okay, so this is what is lacus lacrimalis. And what is this tissue? Can you see this? This is called caruncle. So this is a place from where the NLD, nasolacrimal duct, goes. Keep in mind. It will have goblet cells also, and it has the nasolacrimal duct. Interesting? Yeah. Okay, so come to the next slide. This we have done again. How the palpebral conjunctiva can be divided as orbital, tarsal and marginal. And of course that groove you will remember, right? Okay, so accessory lacrimal glands which are present in the fornix, that is your gland of Wolfram and gland of Krause. Keep that in mind. Rest you all know. And of course, meibomian glands are in the eyelid. When we are going to learn eyelid, we will know. Okay? Simple anatomy of the conjunctiva. See, this is your epithelium. If you look at the histological picture, this becomes your epithelium. This is the superficial loose, that is your substantia propria or adenoid layer. And the rest of the stroma is what is called fibrous layer. Simple. Done? Okay, come to the next one. Okay, when we talk about the blood supply, I don't want you to learn too many things about it, about the different arcades that is formed. So making things simple for you, let's note down. Bulbar conjunctiva, mainly if you see here, it is mainly the anterior ciliary artery. Note down on your copy, please. I'm writing here. So bulbar conjunctiva mainly supplied by anterior ciliary. I hope you remember if you attended the introduction part. It is mainly muscular branches. All are branches of ophthalmic artery, right? So you can learn like this. So anterior conjunctival artery, posterior conjunctival artery, both are supplying the bulbar. Coming to palpebral and fornix, we will just learn the names of two arcades. The two arcades that we are going to learn, just know the names for palpebral and fornix. What are the two arcades which are supplying? One is your marginal tarsal arcade and second is your peripheral tarsal arcade. Because there has never been any exam question on the blood supply, we will not invest too much time here. Just remember marginal tarsal arcade and peripheral tarsal arcade. Right? So, everything is a branch of ophthalmic artery to make your life simple. Okay, so talking about this, we come to another. So, generally these arcades, if you are more curious and you want to know, it is supplied by medial and lateral palpebral arteries. These arcades are formed by, if you want to know further, medial and lateral palpebral arteries. We come to the next important thing is, we should also mention here that conjunctiva is one tissue where there is a lymphatic supply. Okay, so medially it is going to be draining into submandibular, please note down, and laterally preauricular lymph nodes. So it's very important in viral conjunctivitis, generally the preauricular lymph nodes are all enlarged. So that you have to keep in mind. Okay, so and the blood nerve supply, of course, it is the sensory supply is by fifth nerve, just as in cornea. Written? Fifth nerve. Okay, yeah. So once we know about this, we know about the lymphatics. Please note down the points that I'm saying. I didn't write this, but I hope you have written. So medially submandibular and laterally preauricular. Okay, so this was about a little bit about conjunctiva, the anatomy and all. We now come to conjunctivitis. What is conjunctivitis? Very simple. It is inflammation of conjunctiva is called conjunctivitis. Everybody knows this, right? Okay. Then we talk about what will be the signs and symptoms and clinical features. I think this is easier if you remember it as 5 fingers. Let me tell you my style. So it was redness, pain, photophobia, blepharospasm. Okay, we will make the 6th finger as, of course, foreign body sensation, which is more important. Right, like this. This becomes easier. And discharge. Discharge. Now, in front of pain, photophobia and blepharospasm, now write down here, this will be if corneal involvement. Or if it is a severe conjunctivitis, which involves the cornea. Okay? So, this way you will remember better. So, 5 fingers, redness, pain, photophobia, blepharospasm, discharge. And of course, very important, foreign body sensation. You can also add discomfort in the eye and so on. Now, when you come to discharge, now it will be easy to learn for you. When you say discharge, what can be the type of discharge? That depends on etiology of conjunctivitis. What is the etiology of conjunctivitis? Again, I have made easy for you. We can write it as BCVA. You know, actually, BCVA is a full form of best corrected visual acuity. So, this is best corrected visual acuity. But I am using it here as different etiologies of conjunctivitis. Easy to learn. So, if it is bacterial, what will be the discharge? If it is chlamydial, what will be the discharge? And viral and allergic, what will be the discharge? Everybody knows viral allergic, it will be watery discharge. Chlamydial, we will learn mucopurulent discharge. Easy. So, this way the chapter becomes very easy. And when you say bacterial, It can either be mucopurulent, it can be just moderately purulent, or as in gonococcal infections, it can be severely purulent, severe purulent. I'll show you the slide also. What is severe purulent? Okay, so these are the different ways we can learn the different types of discharge. It depends on etiology. Okay, so I know what is conjunctivitis, I know how the patient will present and what can be the problems there. I also know what are the different types of discharges and how it will be a hint to the etiology. Okay, what about, we are still there, on examination, what signs I can see in this patient? So the signs that I can see in this patient, let us think ourselves one by one. Of course, there will be redness, yes. One is redness. Now, before I move further, do you all know what are the types of redness in the eye? What are the types of redness? Depends on etiology of the problem. So, there are two types. Let's make a diagram and be clear. You must have learned this in your MBBS also. When the blood vessels that are near the limbus are congested, they are straighter, draining from the limbus to the fornix. These are the deeper vessels. These are ciliary congestion. Ciliary congestion is mainly seen in corneal involvement, in glaucoma, in uveitis. That means serious pathology. But if I am only getting conjunctival blood vessels are inflamed, we call it conjunctival congestion. What is the difference? You can see this is more branched, isn't it? And conjunctival congestion is going to be present when there is a conjunctival pathology. That means all causes of conjunctivitis. Correct? So here, what type of redness if I ask you? It is conjunctival congestion. The redness you will learn it as conjunctival congestion. Okay, what else I can see apart from conjunctival congestion? I can see chemosis. What is chemosis? Everybody knows? Edema in the conjunctiva. We'll just see the slides. That will be like a revision for us. Keep noting down first. Okay, chemosis. I can also see follicles and papilla. What are these? We will talk about it shortly. Note down, there can be follicles, there can be papilla. Then on examination, I may be able to see some subconjunctival hemorrhages, right? Or I may be able to see some pseudomembranes, or it could be a true membrane. These are the different signs I can see according to the type of conjunctivitis. Okay, so once we know what we can see, now we talk about whenever there is a conjunctivitis, pathologically you can say you can divide the reactions as two types. So whenever there is a conjunctivitis, the pathologically you can classify it as there is a follicular reaction or it is a papillary reaction. Now what are these? Follicles are nothing but these are aggregation of lymphoid cells. Keep in mind these are aggregation of lymphoid cells. Right? So follicles are aggregation of lymphoid cells and this will be because it is maximum in the fornix, follicles are maximum in fornix. Keep in mind. So another interesting fact here is, so when you say follicles, it is mainly we are talking about these lymphocytic aggregation in the adenoid tissue. Okay, and adenoid tissue does not develop from birth. It develops only after 2-3 months of the age. Therefore, no follicles in neonates. Keep this in mind. Why no follicles in neonates? We can say because adenoid layer develops after 2 to 3 months. After 2 to 3 months of age. Okay. What is papillary reaction? We have also learned papilla in case of your, if you remember, when we will be talking about vernal conjunctivitis and so on. So papilla is nothing but epithelial. So papillary reaction is what? Epithelial hyperplasia. It is epithelial hyperplasia. Done? So this epithelial hyperplasia that is happening along with the lymphocytes and plasma cells which are aggregating, and very, very important, which is a main differentiating point pathologically from a follicle, at the center there is a blood vessel. Keep this in mind. This is all what is called papilla. So this is what is a papilla. Okay. So once we know what is a papilla here, Also keep in mind, what are giant papilla? More than 1 millimeter size. When it is more than 1 millimeter size, we will call it giant papilla. So that was a pathological reaction. We know what is conjunctivitis, what can be the presentations, on examination findings, and we now know what can be the pathological reactions and why we are getting a papilla or a follicle. Correct? Okay. Now we talk about what will be the treatment. So, if you talk about the treatment, that will again depend upon etiology, isn't it? So, again I can write it as BCVA. If it is bacterial, of course antibiotics. See, it's very interesting. What will you give? It is chlamydial. Antibiotics. I will give antibiotics. What if it is viral? Again antibiotics. Why? Because it's self-limiting. We generally give to prevent secondary infection. We are giving it to prevent secondary infection. And if it is allergic, of course, then we have to go for anti-allergics or mild steroids. Just note down as of now, it can be anti-allergics or mild steroids. So this is a general idea about conjunctivitis, how we are going to approach and what are the different etiologies. Done? Now let's take one by one. What are the different conjunctivitis we have to discuss? Okay, if I say acute bacterial, one of the most common, we know what we will have to do about it. So one by one, let's think this way. If I give you the heading acute bacterial, when I say acute bacterial conjunctivitis, what is very important to keep in mind? What they can ask you is most common etiology. We will answer as usual Staph aureus, or the second option could be Streptococcus pneumoniae. Staph aureus or Streptococcus pneumoniae. Okay? Okay. What can be the clinical features? I think it is the same 4, 5, 6 features how the patient will present. We all know this. Not difficult at all. The same findings can be seen, which the baseline we have discussed. Once we know the same features, I'm not going to repeat it. We come to treatment, we'll write antibiotics. Now suppose it is severe, like in gonorrhea infection. So gonorrheal infection, we will talk in ophthalmia and neonatorium also. It can lead to corneal involvement, corneal perforation as well. In that case, you have to have a very aggressive treatment with all the third generation cephalosporins. One more thing you can add here is in etiology is Haemophilus influenzae, which is common in children. We need this to be mentioned here. Apart from some more in the list, I don't want to unnecessarily give you the list to mug up, just the important ones. Okay, so you know what is the clinical feature and you also know how to treat it. We haven't talked about investigation. Generally not needed. It's a clinical diagnosis is sufficient. But if they ask you or if you, for your knowledge, you should know the basic investigation of scraping and microbiological staining, and sometimes you may need a culture. Okay, and what else I can do? Most accurate is always PCR. If I talk about investigations, the most accurate can be PCR. So if you want to list down the different investigations for conjunctivitis, you could have written it earlier also, but if you just for your sake, nobody is going to ask you so much, and it's generally and commonly we don't investigate conjunctivitis, right? Unless and until it is very much needed in a difficult case. So you can still note down about microbiological investigation, that is staining, culture can be part of it, can be one thing. Secondly, most accurate is PCR. We can also mention immunofluorescence microscopy. Complete the list by this, immunofluorescence microscopy. Sometimes biopsy may be needed. Let's see a few slides. Yeah, so coming to these slides, we already know what is a congestion in the palpebral conjunctiva. Can you see the blood vessels are vertical? This arrangement is also important to appreciate, because when there is a scarring, there will be interruption in this arrangement, array of these blood vessels, right? So this is your congestion in the palpebral conjunctiva. All these signs which we have just learned. This was what is conjunctival congestion. Can you all appreciate this one? So this is all the branch blood vessels that are seen. The same, this is more branched. And if you look here, these are straighter, isn't it? So these are more straighter ones are ciliary congestion. And this is what is edema of the conjunctiva, which we call chemosis, and can be very severe also, as you see in this case. This is also congested conjunctiva with chemosis. Right? Okay. Next one, what we have? Yeah. So these are the subconjunctival hemorrhages. Now, there are many causes of subconjunctival hemorrhage. We are going to list it down shortly. These are the follicles of the lower palpebral conjunctiva. Follicles are mainly more common after a viral infection. Okay. These are sago grain-like follicles of trachoma and the upper palpebral conjunctiva. So again, I am just showing you the signs here. These are follicles. Typically, this look is for the trachoma. And these are the papilla, which are flat-topped area. This is a papillary reaction or papilla. Right? See, I was telling you, this could be, what can be the type of discharge? Look at this discharge, look at this. This is a purulent discharge. So this becomes your severely purulent discharge, mainly seen in gonorrhea, right? So it has been your exam question. Let me mention it here only when I remember. Make a cue. Which is the most dangerous infection in children? And 4 etiologies and 4 names of the 4 bacteria were given to you. So in that case, please remember, we have to answer gonorrhea, right? So gonorrhea, as I just mentioned earlier also, can affect or involve the cornea and can lead to corneal perforation, and hence it is considered most dangerous. This is the reason sometimes, and these children may also get systemic involvement, and that's why I mentioned you that we may have to start a 3rd generation cephalosporin systemically, like ceftriaxone and so on. Right? Otherwise, of course, topically you can treat with quinolones and broad spectrum antibiotics. Right. We come to the next slide. What is this showing? As I said, any bacterial infection will be presenting with some purulent discharge. So this is the purulent discharge out here. What are you looking at? So this one is your pseudomembrane. This one is really bad, covering almost the whole of the corneal area. This is your pseudomembrane. So we will come back to the slides later. Let's write down next after this. We have talked about the general idea of the conjunctivitis, its causes, its features, pathological reactions, and how we can treat it. Now we take one by one. We will start learning with specific types of conjunctivitis. So first heading is your pseudomembranous conjunctivitis. We have already talked about acute bacterial general conjunctivitis. Now I am saying it is pseudomembranous conjunctivitis. So what are the things you have to learn? See, I have made your life very simple. We will just learn like this all the features that we have learned for in bacterial conjunctivitis, right? All the features of conjunctivitis, plus there are pseudomembrane formation. What is a pseudomembrane? It does not bleed on peeling. It is mainly constituting of the exudates, which is adherent to inflamed epithelium of the conjunctiva, conjunctival epithelium. This is what is a pseudomembrane. And please remember, this has been your cue that it does not bleed. Many of you have confusion, ma'am. Is this one for pseudo or true? Please understand, this has been checked many times. We will answer does not bleed on peeling for pseudomembranes. Okay? Okay, so that is pseudomembranous conjunctivitis, which does not bleed on peeling. Now, this pseudomembranous conjunctivitis, what can be the etiologies? Mild diphtheria. Severe diphtheria causes membranous, but mild diphtheria can lead to pseudomembranous conjunctivitis. Okay, then let us not forget Streptococcus hemolyticus. Of course, we can also include Staph aureus and Gonococcus. So these are the bacterial causes. So one cause you can note down is bacterial causes of pseudo. So we are talking about etiology of the pseudomembranes. Very quick, you have to just remember mild diphtheria and Streptococcus hemolyticus is most important for you to remember. But yes, other bacteria which can also cause pseudomembranes. In viral causes, very important is severe adenoviral infections. This is the one we will learn. Okay, and apart from this, yes, even simplex, herpes simplex virus. And of course, the third cause of pseudomembrane could be chemical irritants. We can just note down chemical irritants. Even this can lead to any chemical injury. It may lead to pseudomembranes as well. Right? So, of course, treatment would be according to the etiology, we have to manage it. Right. We come to the next type of specific is membranous conjunctivitis. Let's see the slide. So, this is a pseudomembranous conjunctivitis which will not bleed on peeling. Same here, this is the pseudomembrane. And what is this? This is also a pseudomembrane and we call this ligneous conjunctivitis. I want you to just know one line about it. It's a genetic condition where you can get pseudomembranes in different parts of your body. This is ligneous conjunctivitis. Can occur again and again. Okay? So, it's also a pseudomembranous conjunctivitis. And what is membranous? When it bleeds on peeling, so membranous conjunctivitis. Now, if you can call it even a pseudomembrane looking at it, but everything around it will help you to diagnose. Okay, so when you say membranous conjunctivitis, next heading. Again, all the features of conjunctivitis we have just learned and discussed. Along with that, inflammatory membrane formation. This inflammatory membrane formation, and what is the sign of a true membrane? This has been your cue. So, true membrane means it will bleed on peeling. Just remember, it bleeds on peeling. Right? And yes, another question. What is the cause? We will answer Corynebacterium diphtheria. Corynebacterium, please write along with me. Corynebacterium diphtheria. And also learn along, okay? Don't write absent-mindedly. Of course, here, antidiphtheric serum is given as a treatment. Okay. So, we next talk about the next type of conjunctivitis we will learn. After this is angular conjunctivitis. It has been your exam question. 2 questions mainly asked here. One is etiology, one on treatment. Angular means 2 angles. We are talking not of angle of antechamber, we are talking of eye. So, the 2 corners of eye. So, write down it is conjunctivitis. Conjunctivitis involving 2 canthi along with excoriation of skin. Involving 2 canthi along with excoriation of skin. Okay. This is excoriation of skin and this is what is your angular. So, have a look at this. This is what is angular with this is the excoriation of skin that you can see here and the congestion is more at the angles. They will ask you what are the things. First is etiology. Of course, very, very important. Make a cue all of you. It is Moraxilla Exenfeld. And now I am telling you few more Moraxilla which can be asked. Write down Moraxilla lacunata and Moraxilla cataralis. Okay. All 3 you should remember. But Exenfeld has been your exam question. Even lacunata has been asked. Second cause could be Staph aureus. Okay? Treatment. Of course, these are all bacteria. I am going to go for antibiotic eye drops. Diplobacilli hote hain. Moraxilla is diplobacilli. So, antibiotic eye drops. And what else I can give? This is your exam question. Zinc oxide lotion. What is zinc oxide doing here? The zinc oxide lotion that we applied is it inhibits the proteolytic enzymes. Just remember it inhibits proteolytic enzymes. So, very, very helpful for excoriation of skin. So, it inhibits proteolytic enzymes. We come to the next type of conjunctivitis is hemorrhagic. So, if you learn this way, it becomes more enjoyable also and easy also. So, hemorrhagic conjunctivitis, again all the features of that you have learned, roughly all those things the patient presents with. Along with that, of course, you will only call it hemorrhagic if there are subconjunctival hemorrhages. Correct? Yeah. So, what can be the cause of hemorrhagic conjunctivitis? We will learn there can be bacterial cause or viral cause. So, bacteria which can cause hemorrhagic, 2 very important are pneumococcus, right? And second would be Haemophilus. When you talk about viral, let us learn very, very important enterovirus 7017. Second, Coxsackie 24. Then learn with me Ecovirus 34. And of course, how can we forget adenovirus? It should have been mentioned a little before. So adenovirus, most common virus causing viral conjunctivitis. Take it? Okay. So if all four are given, there was a question, all four viruses are given and they're asking you which is the cause. Now how will you do? What will you do about it? All four are the causes. We prefer this one. I don't think this question will be repeated. That was repeated because there was it was spread a lot. It was a total endemic at that time of enterovirus 70 when this question was asked. Very fond of asking this question then. Anyway, then we talk about, once you know the causes of hemorrhagic conjunctivitis, our next thing that we have to discuss is what can be the other causes of subconjunctival hemorrhage. So let's think of ourselves, subconjunctival hemorrhage. You know, if a patient comes to me with a subconjunctival hemorrhage, my first question is trauma, history of trauma. Once he says, no, there's no history of trauma, my second concern is monitor your blood pressure. It could be hypertension. And the blood pressure, I will suggest to measure the blood pressure 3 times a day at least. Okay. After this, there could be other causes like foreign body in the eye. When you're rubbing it, it can lead to subconjunctival. Even sometimes contact lenses, though rare for the soft lens. Then bleeding diastasis, when BTCT is more. Again, this is not a very common cause, but yes, you have to mention. And of course, pertussis, whooping cough, or any cause of severe cough, you can say, sneezing, vomiting, it can lead to subconjunctival hemorrhage. Okay, so but generally we will mention pertussis, that is whooping cough. These are the causes of subconjunctival hemorrhage. I just showed you the slide of subconjunctival hemorrhage, right? Okay. So these are the different type. What is the next type of conjunctivitis that we have to learn? Please give the heading, trachoma. We'll talk about trachoma. Okay. It's a chronic conjunctivitis for children or adult? Children. Okay. So it's a chronic conjunctivitis in children. Caused by, what will you answer? We all know Chlamydia trachomatis. Which strain of Chlamydia trachomatis? It is in children. So easy to learn, ABC. So it is A, B, B, A and C. Right? Okay. One very interesting thing. It is most common, preventable and irreversible cause of blindness worldwide. So it's a world's, this has been recently claimed, just let us learn this. It becomes the world's leading cause of preventable and irreversible blindness. Will remember this? And irreversible blindness. Okay, when you're talking about the strain of trachoma, what are the other strains we have to know? So a little bit about that Chlamydia trachomatis. If we look at Chlamydia trachomatis, it is either TRIC, that is your inclusion, trachoma inclusion conjunctivitis agents, or it could be causing lymphogranuloma venereum. We know this, right? So LGV agents. This causes lymphogranuloma venereum. So lymphogranuloma venereum will also lead to conjunctivitis. Okay. Along with that, there can be fever and preauricular lymphadenopathy and so on. Yeah. So the strains here, what we mention is L1, L2, L3. Now coming to the TRIC. So this trachoma inclusion conjunctivitis agents we divide it in two types of strains. One which is causing trachoma in children, and that is your A, B, B, and C. Easy? And the second you will learn is adult inclusion conjunctivitis. Now, adult inclusion conjunctivitis is caused by D2K. Just let us learn, it is caused by D2K, the strain D2K. Now, very interesting. The strain D2K, this conjunctivitis that it causes is also known as swimming pool conjunctivitis. All of you put a Q there again. Swimming pool conjunctivitis. Right? What is the other cause of swimming pool? Other cause of the swimming pool can also be adeno, which is even more common than chlamydia, adenovirus. Here also the conjunctivitis that is cause we call it swimming pool. So swimming pool conjunctivitis, two etiologies. One is D2K, chlamydia trachomatis, and second is your adenovirus. Right? Okay. Once we know this much, we come back to trachoma. If the child is suffering from trachoma, what are the clinical features and how the child will present? So generally, trachoma is common within 1 to 9 years, you can say, 1 to 9 years of age. Keep this in mind. Now, the child is going to present with, of course, lot of itching, okay, itching. And second is, of course, what is the discharge in chlamydia you have learned with me? Mucopurulent discharge. So there is itching, which is too intense, and along with that, mucopurulent discharge. What are the examination findings? On examination, what I see? We'll always draw a diagram and learn. On examination, what I see is number one, follicles typically on the upper palpebral conjunctiva. I just showed you the slide. These are sagogranous sabudana, right? So it is sago grain like follicles in the upper palpebral conjunctiva. And also we will learn the same follicles can also occur here in the upper limbus. Okay, the one that are on the upper limbus are called Herbert follicles. So this is an active inflammatory stage. So if you divide trachoma into two stages, active inflammatory stage or chronic scarring stage. Okay, so psychiatrical is scarring. So chronic psychiatrical stage or active inflammatory. So we are talking about active inflammatory stage. What are the findings? So findings are a lot of itching, mucopurulent discharge, and when I am seeing this patient, I can see Herbert follicles or sago grain follicles on the upper palpebral. Anything else apart from this? Upper palpebral conjunctiva. And apart from this, yes, there can be corneal vascularization, which we call pannus, right? From the rete ridges, the vessels can actually invade the cornea. So another finding, okay, let's mark it with the red here. Yeah, let's do it with the red. Write down, we can see pannus. So this is mainly blood vessel with some lymphocytic infiltrations. Okay, so that is your pannus, and yes, there can be some corneal epithelial defects. Let's mention that as well. There can be corneal epithelial defects. Okay, so this is all active inflammatory stage. Then we come to the next stage that will happen is it follicle only or do we get papilla also? Yes, we are also getting a papilla, please remember. So this is your exam question. So pathologically, trachoma is that infection where there is, make a Q, both papillary and follicular reaction. Okay, so it is both papillary and follicular reaction. Okay? Okay. Coming to the psychiatrical chronic stage. So the next stage, if nothing is being done in this disease, it will lead to chronic psychiatrical stage. So what will you see in this when there is a scarring? We'll again draw the diagram and learn the features. So the first ever follicles. So these follicles in the upper palpebral conjunctiva, when they scar in a linear manner, and that linear scar is what is called repeated cushion Art's line. And when the scarring is on the upper limbus here, Now this is what is called Herbert Pitts. Please remember, both are repeated questions. So we cannot afford to forget these terms. So when you say a chronic psychiatrical stage, it is mainly leading to all this. It is, please remember, at this stage the reaction is type 4 reaction. It's a part of type 4 hypersensitivity reaction that you are getting all these changes. Anything else? Of course, there is corneal vascularization. Corneal vascularization of Panis, this is also seen. And any scarring, think yourself, when there is a conjunctival scarring, it can lead to interning of the lid, which is called entropion. So it can lead to psychiatrical entropion. What will happen? The lashes have started rubbing the cornea. So this misdirection of eyelashes, what is called due to scarring, is trichiasis. So another finding you can label down here is, so we will label here trichiasis. And any rubbing which is causing corneal opacity, right? So this is causing any rubbing of the eyelashes on the cornea is going to lead to corneal opacity. CO is corneal opacity. These are all the findings of chronic psychiatrical stage, right? So we can learn all this in form of WHO grading, which is very, very easy to learn. Give the next heading, WHO grading. Everybody knows this. So WHO grading, everybody knows it. The mnemonic to learn is FIST-O. So we can divide it into 5 stages. This is stage 1. F stands for follicles. It's easy, they won't ask you. What they will ask you? How many follicles? So let's remember 5 or more than 5 follicles. We know what are follicles now. Where, upper or lower? This is the next question. In the upper palpebral conjunctiva. It is in the upper palpebral conjunctiva. Come to second stage is I, inflammatory stage. Again, inflammatory stage we all know, where the patient is follicles everywhere. We have learned that. So inflammatory, the patient is complaining of itching and of discharge. So this is all inflammatory. What is the next stage? We all know is the chronic psychiatrical scarring stage. Scarring means arch line Herbert Pitts. And this scarring is leading to one problem here, that is misdirection. So if you see a single eyelash also misdirected, you will put this patient into stage 4. Remember that. So trichiasis, and fifth is your corneal opacity. So corneal opacity will happen. Why? Because there is corneal ulcer. When it heals, it leads to opacity. This is the WHO grading of trachoma that we have to learn, or WHO classification of trachoma. Now, once we know this, there is a very important question they have asked you. What is the complication of trachoma? What is the complication of trachoma is a very, very important question. And remember, it is only one. And that is corneal ulcer, which is later leading to opacity. Rest all the effects of the scarring like entropion, trichiasis, these are considered sequelae of trachoma. Complication only one, that is corneal ulcer, which will later lead to corneal opacity. Right? Next thing that we will learn about trachoma is the pathology. If we learn under headings, it's better, so I am mentioning under heading. 2 points that we have to learn, both are exam questions. First was, it is both follicular and papillary reaction, already mentioned to you all. Second, they have asked you about the intracytoplasmic inclusion bodies which replicate, we call them reticular bodies, right? And which are not intracellular, these are elementary bodies. So, not going into that detail, just remember intracytoplasmic inclusion. Sometimes they have asked you, this is HP bodies. Write down intracytoplasmic inclusion bodies. HP stands for Halber-Stidter-Provezak. Right? Okay. Another thing that they will ask you, or they have asked you, is related to all this community ophthalmology, that okay, when you talk about trachoma, even I think last year in AIMS also this was a question about safe strategy, isn't it? So we have to, okay, let me discuss this in treatment. First of all, one more thing before that. If I ask you what is the investigation, again, generally majority of the time it's a clinical diagnosis, we don't need to investigate. Okay, Of course, you can go for all these enzyme assays, or the investigation of choice, what did I tell you, was PCR, isn't it? Investigation of choice, if they ask you here, of course, if I have to be very sure, instead of anything else, let me go for PCR, right? By the tarsal and conjunctival scraping. Another thing that you have to keep in mind, if you have to go for a culture, what was the name of the culture? Cell culture. I'm going into microbiology a little bit here, which is highly specific, is your McCoy. Okay, these are the two things I'll mention here, right? So, and if you go for a GMSA staining, you can even see the intracytoplasmic inclusion bodies, right, by GMSA staining. It helps to see the HB bodies. Okay, so apart from the enzyme assays, immunoassays that we can go for, what is the cell culture, what is the investigation of choice, this much idea you should know. Now, when you talk about the treatment, now this is a repeated question. How are we treating now? What is the way we are treating, and this is safe strategy, isn't it? So please remember, what is safe strategy? This has been a repeated question recently asked. We all know it stands for surgery. Which surgery? For trichiasis, isn't it? For entropion and trichiasis, whatever surgery you're doing, generally we will say preferably, if both are given, you should answer trichiasis. Okay, so this surgery generally what we go for is bilamellar tarsal rotation. We don't need to go into too many details here. Let's remember this. The surgery is primarily for trichiasis and entropion. It's almost the same thing because entropion is and they go together generally, right? So there was only one question where they were given as choices, then we had to answer trichiasis. What is A for? We all know antibiotics. So what are the antibiotics I can give? I can go for either option. I can go for azithromycin or I can go for tetracycline. Now, what is the treatment of choice? Definitely it has to be azithromycin, right? So, azithromycin 20 milligrams per kg in children. You have to remember, and in adults 1 gram. Isn't it? We know this. So, this is important. And why not tetracycline? So, you have to understand here, 1% tetracycline is considered less effective than oral azithrom. Very, very important. And second important thing is, it is very cumbersome. Compliance is very poor because you have to keep putting ointment. And also tetracycline has its own disadvantages. In children, if you are going to give, it can lead to different problems like tooth staining and so on. Generally, it is contraindicated in children, right? You know more about details and side effects of tetracycline. But still, they have asked you, if you are giving, what is the percentage? Make a Q and write down it is 1% ointment. But I would still prefer azithromycin, which is more effective, easier to use, and more safer. F stands for what? Facial hygiene, and E is environmental cleanliness. Right? So, facial hygiene and environmental cleanliness. That was about your safe strategy, and this is how you should be ideally treating a trachoma. Okay? This is the strategy for control of trachoma in any community. Now, if you are deciding to control the trachoma in any area, you generally know it is happening in a less hygienic area with therefore poor and lower socioeconomic groups. So this disease is more common, right? So if I have to decide for whether I should start a safe strategy in this area or not, what is the factor? We see the prevalence of trachoma follicles. That is stage 1 of the WHO. We see it in 1 to 9 years of children. If it is more than 10%, then we start with the safe strategy. Okay, so please remember this. So it's a related to community ophthalmology question. So this is important, asked in the exam. That whether I should start or not in this area, it all depends upon the prevalence of trachoma follicles. It should be more than 10%. Now suppose the prevalence is 5% to 10%. It is between 5 to 10. Then F and E is followed only. Facial hygiene, environmental cleanliness. And less than 5%, we don't bother to do anything in that area. Of course, F and E should always be followed. But this is under the program, nothing is done. Okay. Now, there's another related question is, what is the drug of choice for blanket therapy in trachoma? This is also kind of blanket therapy, but here we mean for prevention. So, drug of choice for blanket therapy, whenever they ask you, you will answer again azithromycin. Drug of choice, azithromycin. For drug of choice for blanket therapy, same, and treatment. Drug of choice for treatment is again azithro, as I just mentioned. Okay? What can be the other options you can give apart from this? Is, of course, don't forget doxycycline or erythromycin can also be given as a treatment modality. So, other options for treating trachoma could be doxycycline or erythromycin. And there is also sulfacetamide eye drops, right? But you have to see that the patient is not allergic to sulfa drugs. Right. So that was about trachoma. Let's see the slides here. So these are the patches of subconjunctival hemorrhage, and what you're looking at here is the hemorrhagic conjunctivitis. Okay. These are the sago grain-like follicles. I think we have already done this. So we are looking at the case of trachoma. This is the neovascularization which we talked about. So this neovascularization is what is called pannus. Okay. And when there is an infiltration which is ahead of the blood vessels, we know that it is going to progress more, and when it is behind, it will not progress. So that this is how we differentiate between a progressive and a regressive pannus. So क्या बोला मैंने? When there is infiltration in front of the vessels, it's a progressive. Just remember this. Here you are. This is what is the scarring and all the vertical area of blood vessels. This scarring disturbing the vertical alignment of the blood vessels here. This is what linear scarring is called, Art's line. We know this. So this is your Art's line. And these are the Herbert pits. This is how it looks like, right? This sacratization is at the upper limbus. This is Herbert pits. Okay. We next talk about, our next heading would be neonatal conjunctivitis, or give the heading ophthalmia neonatorum. So how do you define ophthalmia neonatorum? Any conjunctivitis within 1 month of age. Okay, so within 1 month of age is ophthalmia neonatorum, or you call it neonatal conjunctivitis. So what can be the cause? Why will the child start having conjunctivitis within 1 month of age? So causes, etiology, write down. First is chlamydia, gonorrhea, number 2, write down gonorrhea, herpes simplex virus 2, Staph aureus, sometimes even H. influenzae, and of course chemical conjunctivitis. Write the way I'm writing, we'll discuss more on this. Chemical conjunctivitis. Now, first question, make a cue. Which is the most common cause of neonatal? We will answer chlamydia. Then they have asked you about the duration when it presents. So learn with me. Earliest definitely is gonorrhea, which is within 1 to 2 days it can manifest. Okay. So how to learn it easily? This is first week, or you can say it can manifest in 1 to 2 days. But chlamydia will take 1 to 3 weeks to manifest. Common sense, if you put any chemical in the eye and there's a chemical conjunctivitis, which chemical? I'll just come to that. It has to be within 24 hours. Within same day, there will be some reaction, right? So within 24 hours or in a day or two, very quickly, I mean to say, right? So they haven't asked you the duration of each of it. I don't want to go into that. Why to confuse you? I want you to learn only these 3. So I'm not giving further. Another thing, keep in mind, whenever we are talking about chlamydia or gonorrhea or herpes simplex, these 3 are mainly due to vaginal delivery. Okay, so the mode of infection here would be mainly this. But yes, it could be other causes like staph and H. influenzae. And chemical conjunctivitis is again asked in the exam, is due to, we all know, 1% silver nitrate, which is given to prevent gonorrheal conjunctivitis if the mother is already infected. Not in every children, but if the mother is already infected, 1% silver nitrate is put in both eyes to prevent gonorrheal conjunctivitis. This method of prevention is what is called Creed's method. Right? So this is what is also important in a Q. Okay? And another Q which I have already mentioned twice to you all is most dangerous infection, gonorrhea. Make another Q, most dangerous infection, gonorrhea for children. Right? Why? It will cause corneal perforation. There can be systemic involvement. We have to have a look at that as well. Right? Okay. Now, another cause apart from all this infection could also be because of NLD obstruction, that there is going to be, in fact, in this child there is some conjunctivitis and infection. Okay, so one cause could also be NLD obstruction. Please note it down. Okay, another important, so these are the questions they can ask you from neonatal conjunctivitis. If we have to learn anything further more here, is apart from your Creed's method, right, where you're giving silver nitrate. So what these days you can, apart from this, of course, povidone iodine is another important method for prevention, right? So if I talk about prophylaxis, we can say that prophylaxis of neonatal conjunctivitis, it could be, instead of that, I'm giving povidone iodine. Of course, even this can cause redness, of course, right? Povidone iodine, number 1, write down here. And of course, silver nitrate, and along with the 1% silver nitrate, we also give, because we are trying to aim for gonorrheal infections, we can go for benzyl penicillin, single dose IM dose of benzyl penicillin. Okay, if there is maternal infection. So, but let's remember here, povidone iodine is one, silver nitrate being the Creed's method as another one. The percentage of silver nitrate should be learned. Or I can go for some other antibiotic I do. So these days, silver nitrate is not that very famous or very favorite modality, as it is causing a lot of chemical conjunctivitis. So not everywhere Creed's method is followed now. We can go for some antibiotic ointments like erythromycin. Okay, so that was about neonatal. Of course, according to the etiology, we'll treat the cause. Keep in mind, whenever we find there is a simplex infection, we always consider it as systemic involvement must be there, and you have to treat it with that vigor, right? You have to investigate, go for the PCR, for even the CSF to check for any encephalitis in the small neonate, right? So otherwise simplex, we all know, we will go for acyclovir. That was about neonatal conjunctivitis. We will next talk about is viral conjunctivitis. A quick look at viral conjunctivitis. When you talk about viral conjunctivitis, etiology 90% are adenovirus. 90% of the viral conjunctivitis is adenoviral. Okay, and of course, another important, what can be the other causes? What needs a special mention here is COVID-19. Right? So this COVID is also causing again acute follicular conjunctivitis. So we should keep this in mind. If you talk about the eye involvement in COVID, the two things that you should never forget, one is your acute follicular conjunctivitis, and second is serious one, and that is it can lead to central retinal artery occlusion. I'll talk about that in the retina chapter. Okay, so what else? What are the other viruses? It could be herpes simplex. Even this causes follicular conjunctivitis with skin lesions. Anything else we can think of? Let's also talk about some systemic illnesses can affect the eyes, like measles, mumps. Okay, so systemic viral illnesses. Measles, mumps, and even varicella zoster, right? And one more term that you must have learnt, you can write down on your page, I'm writing here, is molluscum contagiosum. I'm going to talk about one line we will learn here. What is molluscum contagiosum? This is mainly caused by pox virus. Okay, so we first talk COVID-19. This is what needs mention. This is done. But before I go further, I think we have already done our homework in baseline that if it is a viral infection, the patient is again going to have the redness, but what type of discharge? It is going to be a watery discharge. And primarily what type of reaction pathological? Follicular conjunctivitis and follicular reaction. Yes, it could also be a cause of hemorrhagic conjunctivitis. We had learned this as well, isn't it? And that lymphadenopathy can be a prominent feature. We'll write everything. First, we will further on adenovirus. So when you say adenoviral infection, so adenoviral infection could be just a normal non-specific type of a viral conjunctivitis. You can just say like this, okay? Follicular conjunctivitis, just like any other. Or it could be a part of pharyngoconjunctival fever. So when there is a pharyngoconjunctival fever, please learn with me. I've made it very simple. No more complications. Just very, very, very important points only to be mentioned here. So this is mainly caused by your adenovirus 3, 4 and 7. If you don't want to learn this, it's okay. What is important I want you to know here? This is what is causing swimming pool conjunctivitis. This one you will learn, right? So it can cause swimming pool conjunctivitis. And then we come to the third one is what is epidemic keratoconjunctivitis. EKC, epidemic keratoconjunctivitis. Now, epidemic keratoconjunctivitis, the point to be remembered here, this is the most common adenoviral among all adenoviral infections. And the strain most commonly is 8. It can be 8, 19, 37. I don't want you to learn that. Just learn strain 8. This is enough. But another important thing, it is most common and it can be also most severe, involving cornea and all. Most severe. 80% will have keratitis. It can lead to nummular keratitis. We'll talk about that in the cornea chapter. So it can involve, most severe means it is involving the cornea leading to keratitis. And of course then, we also know adenoviral can also cause, I'm writing on the next page now, these three, come to the next one. It can also lead to hemorrhagic, we have mentioned this. One form of infection could be hemorrhagic conjunctivitis. 1 or 2 or more, and let's not mention that, it's enough. So these are the different ways adenoviral can affect our eyes. Okay. Then we talk, how will the patient present? Of course, the patient is going to present with, if cornea is involved, there is pain, otherwise redness, conjunctival, congestion. All those 5 fingers that I taught you can happen. Discharge should be watery, should be mentioned here, watery discharge. There could be subconjunctival hemorrhage in case of hemorrhagic conjunctivitis, right? And don't forget lymphadenopathy, preauricular lymphadenopathy. This is the most common. This is seen mainly in the viral diseases, right? So all these things, all these findings, and of course, corneal involvement and keratitis can be a feature. So pain, photophobia, blepharospasm, especially when there is keratitis. Easy? Okay. Again, investigation is not specifically required, and treatment, I have already taught you that antivirals are generally not given unless and until it's a herpes simplex, and what we go for is for antibiotics to prevent secondary infection, right? Okay. Then in our list, do we need anything else to mention? Simplex we will learn more in detail in the cornea chapter. Of course, as I said, if it is simplex, I may need some acyclovir, but that also is needed only when there is a corneal involvement. More needed then, right? Okay. Then we talked about molluscum contagiosum. Let's see the slide to understand. We come back to the slides here. So you're looking at this child. This is a case of neonatal conjunctivitis with discharge that you see here, right? Again, lot of swelling, discharge. Now here, if you realize, the discharge is watery. This is what you have to know. Swelling of lids and watery discharge. So these were the slides for your ophthalmia neonatorum. right? Whereas here we are talking about viral conjunctivitis with watery discharge. This is all your follicles, and these are generally this time in the lower palpebral. In viral conjunctivitis, it is in the lower palpebral conjunctiva. Trachoma, it was upper palpebral. Keep that in mind. This is more common in lower. This is what you mean to say. Okay. Then we talk about here, it is showing you the preauricular lymphadenopathy. Right? This is what is this. Can you see this waxy round lesion here? This is what is molluscum contagiosum. So, it is eyelid margin. The lesion is in the eyelid margin, is showing you this waxy umbilicated nodule. We describe it as waxy umbilicated nodule. Write down. This is what is a viral infection by pox virus. We call it molluscum contagiosum. You may need to excise it. These are the only points I would like you all to remember, nothing more. Okay? So that was about viral conjunctivitis. Our next heading would be allergic conjunctivitis.